All right, so I'm just gonna, so the part not knowing what the group that's covering HIV was going to talk about, I just thought I would hit some of this stuff because typically we have in years past, before COVID, we've had a guest speaker come in, the instructor from Russell Street. She would come in and she would give kind of a nice presentation on HIV. And then we have this great guest speaker who is probably going to be available like next year. But last year he did a recorded lecture, and then this year it was just too much to try and coordinate. But he's a patient living with AIDS, and he's just got a really interesting story. And he was fortunate enough to have some excellent medical attention back when he was first diagnosed with AIDS back in the, I don't know, the early 90s or something. And so he's outlived a lot of his peers, and he just has a great story. So that's why on the schedule it says hopefully, but it just didn't work out for the guest. But we usually do a pretty in-depth section on HIV and AIDS. So I wanted to just cover a little bit this way, and then the group that's covering it will hopefully kind of complete the circle. But if not, you guys can always reference my PowerPoint to see how they kind of line up. And I'm sure you guys have done an excellent job, the group who's covering HIV. But just in case, you can use it to sort of fill in the blanks a little bit, if there are any at all. So these are the objectives that I probably just haven't unhidden it. You want me to unhide it now? Oh, okay.
I like to see,
oh, you like to, yeah, yes, that's fine. Hold on, just let me get out of here.
sorry.
No, you're good.
You don't have a recording for this lecture, like you're just gonna go over some segments, like you can listen to like oral med last term.
Okay, so I'm just going to unhide both of these. So now you guys will see the HIV and oral health, and then you'll see the eating disorders. That's okay. Okay. Okay, back to it. So I'm recording what I'm talking about now, and then I do have a recording from last year that I can put up there as well. So I do have a recording from last year. Okay, so these are the objectives that we want to hit overall between the group presentation and then this PowerPoint. So you can look over those to see kind of what we want to highlight. So HIV, human immunodeficiency virus. The first case was reported to the CDC in either June or July of 1981. So it's been 41 years, 42 years or so since they first kind of hit the scene. And it was reported as an opportunistic illness. It didn't of it in the beginning. The causes, it's acquired immunodeficiency syndrome is what AIDS, acquired immunodeficiency syndrome. And it took them a while to figure out, kind of how it transitioned from HIV to AIDS and that whole process. Now they have a far better handle on it, and they have a huge range of medications that treat it. So now it's basically a treatable chronic medical condition. People, some of the interesting things that I remember from the guest speaker was talking about how people now can be so controlled with their medication that their viral load is almost non-existent. So their serum, when they have their blood test, it's almost non-existent. So it's pretty amazing what they've been able to do so far. But what happens is in the beginning, especially, or if it's uncontrolled with medications, there's this sort of gradual impairment of the host immune system. So the CD4 cells, which are one of the T lymphocyte cells in our immune system, they just kind of get wiped out. And so once you get down below a certain level and your CD4 cells are sort of below like 200, someone's going to remember better than me, but it's like right around 200. It's in the PowerPoint, I think. then you basically cross over from HIV to AIDS. So they're monitoring that cellular level there. So I really like this diagram. I kind of think I showed this to you guys in oral med. Does this look familiar?
Yeah.
And I like this so much because these stop signs these are the different kinds of medications that they use with AIDS and HIV. And so there's these stop signs. So not only does it show you sort of the life cycle of what's happening, so we have the binding phase where the virus comes in contact with the CD4 cell. So this big cell, the yellow and the purple, is the CD4 cell. And then the little spiky looking ones is the HIV virus. So in the first phase, the HIV virus comes in and it binds with the CD4 cell, and then it shows the HIV's genetic material inside of the virus there. And at that phase, they can use things called CCR5 antagonists or post-attachment inhibitors. So they're basically trying to make the HIV virus not stick to the CD4 cell, not connect to the CD4 cell. So that's, but if it does bind, like over here, it binds onto these little receptors, then it starts the second phase, which is fusion. So it starts fusing with the cell wall of the CD4 cell, and it starts kind of coming in so it can actually dump its genetic material into the CD4 cell. So here we have another medication that they can use that's various fusion inhibitors. So I just love how you can actually see this process. And then here we have the reverse transcriptase process starts to happen. That's number 3. So inside the immune cell, the CD4 cell, HIV releases and uses reverse transcriptase, and they do that with a certain enzyme. So they do this to convert its genetic material to HIV RNA. So it's basically like this is different from a DNA virus. This is an RNA virus, sort of like COVID is an RNA virus, not a DNA virus. You guys, this is totally off subject, but do you guys know what like polio and I'm trying to think of another one, chicken pox, are those DNA viruses or RNA viruses? Just random, so not on the same topic, but those are DNA viruses. Those are they're just different types of viruses, the DNA viruses. I just find that interesting for some crazy reason. I don't know why. And so anyway, so the HIV dumps its RNA or its material in there, and it starts this process where it's conversion. And now once it's converted, it's able to get into the DNA, it's able to get into the core, the center there of the cell, and change the actual DNA of the immune cell. So that's what's so sneaky about it, is it comes in and then it's able to actually unlock and get into the DNA. Once it adds its, and so then you have that integration. So once it comes in and it integrates itself into the DNA of a CD4 immune cell, now it can come out and it can exit the cell and start replicating itself throughout the body. So it's a little bit of a process, but you can see, you can follow it through with this diagram. Another really interesting thing is if you come all the way down here to the budding, the seventh step, you come all the way down here. So newly formed, immature, non-infectious HIV pushes itself out of the host CD4 cell, and the new HIV releases protease, which is an HIV enzyme, and the protease acts to break up the long chain that forms the immature virus. And the smaller HIV proteins combine to form mature infectious HIV. So the last drug that you hear pretty often are protease inhibitors. And the reason why I mentioned that about the viruses is because a new medication that Pfizer is just doing an emergency use authorization for COVID is their protease inhibitors. So it's a similar, so what hopefully might work to treat COVID as a treatment that looks really promising are protease inhibitors. And we've been using protease inhibitors for a long time with AIDS. So it's kind of interesting the way that matches up, RNA viruses, protease inhibitors, it just kind of all matches up a little. So I just think that's really interesting. So basically the main mechanism of action, HIV, suppresses the immune system. It decreases the ability of the body to mount a natural immune defense against disease-causing agents. So the number one problem is that they just are going to be more susceptible to opportunistic infections. Bacteria, fungus, viruses, it's just wiped out some of their ability to fight some of these. So by some estimates, more than 90% of HIV infected patients will have at least one HIV-related oral manifestation. And we'll look at those later. And I'm not going to really go into those. I'm going to let the groups go talk about that. So opportunistic infections, illnesses associated with severe immunosuppression. And one of those that you'll see is a rare cancer of the blood vessels, which is called Kaposi sarcoma. And that's Kaposi sarcoma is a good one for boards. They love asking about that. So make sure you're really familiar and you know that that's connected with HIV and AIDS. Yeah, kind of. Yeah, it's real, and it can be intraoral, but it can also be on their body in other places because it's a cancer of the blood vessel. So the actual blood vessel kind of proliferates and grows. So you can see big lesions on the outside of the body or in the oral cavity.
Yeah.
So that's, if you just kind of connect those two things and, have a few, a little understanding about, the basic mechanism of it, that's a kind of a good question that they like to ask on national boards. Okay, so how does HIV hijack the immune system? So we already kind of looked at it through that little cascade flow chart. But basically, the CD4 cells their DNA is sort of taken over by the HIV DNA. And so they kind of utilize it, or they hijack those cells to proliferate and to kind of take over. So they kind of use them as their, mechanism or their vehicle to replicate and then to spread throughout the body. Once DNA is established, it can integrate into the host cell's genome. And then now HIV can circulate and infect other cells. So not just the CD4 cells are affected, but other cells throughout the body. The virus suppresses the host immune system and they have no natural defense, which we are. So how can it be transmitted? So in the beginning, it used to freak everybody out because they didn't know, oh, can I hug and kiss and touch and shake hands, or what can I do? So we know that the transmission is through semen, vaginal secretions, breast milk, and infected blood or platelets. So we know that saliva is a very low, if not AIDS. And then let's see, I'm just read my notes here. It's been reported that most persons who are under seroconversion, meaning converting from HIV to AIDS, often are ill enough to seek medical attention. Oh, so once somebody hits that range where their immune system is sick enough to be actually converting from HIV to AIDS, they're seeking medical attention. Like they feel really, really bad. So usually somebody who's at that phase knows it. You might not necessarily see them in the dental office. Acute HIV infection is also characterized by primary or an initial spike in the viral levels in the bloodstream. So usually initially when it's first happening, there's a spike of the virus. So it might take 6 to 56 days after exposure for that to happen. And patients can experience fever, lymphadenopathy, headache, rash, pharyngitis, malaise, and arthralgia, aching joints. So they can experience a number of different onset symptoms. So it used to be in the beginning that they only had one therapy, and then patients would formulate, the virus mutation or the patients would adapt to it and the drug wouldn't work anymore. So they would kind of go through one therapy, wouldn't work, go through another one, it would work for a while, it'd stop working. And they'd go through like drugs until they kind of ran out of options. Nowadays, they have kind of a cocktail. They refer, and I know we talked about this last semester, but they call it the HART therapy, HART, highly active antiretroviral therapy. And it's usually at least 3 different drugs that people will be taking. Today's HIV regimen are all better tolerated, easier to manage compared to the earlier regimens. They're recommended for everyone diagnosed with HIV to preserve the immune system and improve health outcomes, treating HIV as soon as it's diagnosed rather than waiting for complications. And like we said earlier, a lot of times they can just consider it more of like a chronic condition that they're managing. I'm not going to talk about oral manifestations. There can be age-related comorbidities that individuals living with HIV and AIDS, non-AIDS defining malignancies, cardiovascular disease, diabetes, bone density issues, and then these comorbidities require consultation with the physician. You have to just take the patient like on a case-by-case basis, because basically what it comes down to is everybody that comes into your chair that has HIV or AIDS, they may have a different comorbidity that they're dealing with. It's not like just a blanket. Like I think is David is his name. I keep wanting to say David, but I could be wrong. But anyways, David, he was talking about how his liver was starting to, he was starting to have to pay more attention to his liver, and it wasn't filtering so well, and his liver numbers were kind of off after years and years of heavy medication. So that's just his situation, but everybody has a little bit of a different experience. But there are usually some age-related comorbidities. They're going to be more at higher risk than other people that do not have AIDS or HIV. So one of the biggest things is this continuation of care. Patients with HIV have to make sure that they are regularly seen, they're being maintained, they're being proactive. That's one of the things that David would say is you have to be proactive in your own health. You have to stay on top of things because they're just going to be more susceptible if they don't take advantage of, understanding how to keep their body the most healthy, then they could, obviously suffer down the road. So timely linkage from care and retention of care, seeing the same practitioners if possible, so they have that continuation, staying on the right medications, early testing and diagnosis, of course. And then the CDC recommends everyone should be tested at least once in their lifetime. And so, I don't know when you would know when the best time to get yourself tested, but anyways, they, recommend that everybody at least, and sometimes we have to just because of some people's jobs, they have to get tested. Yes, I watched all the episodes, but I don't remember,
Remember she never got tested for HIV ever in her life? And she has a partner that was like, why have you never done that?
Yeah.
A whole
and she's like, I don't know.
Yeah.
Oh my gosh, I actually own all of I own the whole thing, and for some reason I don't remember that episode. I'll have to go looking for it. It was a while ago that I watched it. Yeah, now I'll just start from the beginning. I'll just start over. Okay, so I don't know if I'm going to go much more. That might be where I end, just because this gets into process of care a little bit. I did want to talk a little bit about, we pride ourselves in our infection control and that we treat every patient the same. So we don't necessarily, every patient that walks through our door potentially could have AIDS or HIV, right? So we treat everybody the same. And even with COVID now, it's the same way. Like we just have to we have to pretend like everybody has some infectious disease, and we don't treat them badly. We treat them equally. You know what I mean? So everybody's treated the same, and it keeps us safe. It keeps them safe. And that is one thing that I really feel has improved dramatically over the years. I feel like there's sort of, I don't think it happens where I see it, but I'm reading stuff that feels almost like we're going backwards a little bit because people are very fearful of COVID. So I feel like there's a little bit of a, like almost a forgetting that that's what we do. And so I just want to take this moment to remind you guys as clinicians, and I think you guys do fabulous, but we don't treat anybody different no matter what they're walking through the door with. That's why we bury ourselves in everything. We have a process for how we break down instruments and how we sterilize. So if you go out into the world and there's talking about, do we treat vaccinated or unvaccinated? Just try not to let that mar your understanding of what we do and how we treat people, because we've never had a problem before. We treat people the same, and that's why we have such high standards, right, for our infection control. So I just wanted to kind of latch on to that because I feel like this is something that terrified the dental community. They were terrified of it back in the 80s and the 90s. And we've gotten to a point where we're like, yeah, we can deal with that. We do all these things and we keep ourselves safe. So I just think that we have to do that with no matter what's going on in the world, because that's, as healthcare providers, that's what you do, right? You're kind of at a higher risk than the general population. Okay, stepping off of my soapbox, I will now say, let's see, I think, isn't it? No. No, it's just, I think it's important to remember that. It just gives us a little bit of a bearing maybe. Planning, so often so when you're planning your care for your patient with HIV, this is the last thing I'm gonna say, then I'm gonna be done. When you're planning your HIV, it's really very similar to planning your care for anybody who doesn't have HIV or AIDS. If they are significantly ill and they are poorly controlled AIDS or HIV, you're going to see a whole different manifestation. But in this day and age, most people are very well controlled. So it's not like you're going to necessarily do that much, other than there may be something in the back of your mind where you're like, if you're at Russell Street and you know that you're seeing, there may be something where you think about your process of closing your instruments and the way you may think of things more, but it's not like you're going to actually do anything treating them different. You're not going to have to lay them back further. You're not going to have to shorten the appointment, unless, of course, there is something specific with them where their health is noticeably not as good because they're not as well controlled, or they're having a problem with a new medication. They'll probably have a very long list of medications, and you can just talk with them about it and find out how those medications affect them. So it's going to be personal to each patient. So I think those are really the main things. We don't have anything with ultrasonic. I don't know if you guys said that in the group who's covering it, but we can use ultrasonics just fine. HIV doesn't float around in the aerosols. It dies very fast. There's a very low percentage, something like 0.3% or 0.03 or 0.3, like a year in healthcare providers can end up contracting HIV through a medical situation, and it's almost never is or never has been dental. I can't remember. Maybe, are you guys covering HIV? Who's covering HIV? You guys. Are you talking about that at all? About the exposure risk? Is that in your? It's super nice, and it's like I think it might be in my PowerPoint, but it's far more likely for it to be, I think, in a hospital. And I don't think there might not even be a case of it happening in the dental field. I have it written somewhere. So we can feel very secure, especially with our infection control procedures. Okay, so I am going to stop there, and I will post. We'll listen to the presentations, and I will also post the PowerPoint from last year too, just in case there are any little things that are missing.